Good afternoon, everyone. Thanks for joining us today. My name's Alex Stratford, and I'm the Executive Director Registrar with the Nova Scotia College of Social Workers. We've been delighted over the last a few weeks here to be hosting this webinar alongside our partners, the Canadian Association of Social Workers. Today is our third part in our web series around client-centered mental health and addiction systems. What we're very excited about is the continued dialogue around not just how we deliver services, but the systems in which they are placed. And we seem to be getting really good results with folks being interested in this topic. Today we have over 793 social workers registered for this. And I think that systems change element is really crucial to our work, particularly in 2017. I'm delighted today to bring back Todd Leader, who's a registered psychologist and a registered social worker who spent the last 26 years leading service development and transformation, as well as health promotion, particularly in areas of mental health addictions and primary health care, to present to us again today. I'm also delighted to say that Todd Leader has joined the Nova Scotia College of Social Workers as our Vice President, and he's just come on board in June, and we're really delighted to have his perspective and voice in our organization. In terms of the process, for those of you who are joining us for the first time, what we'll do is Todd will present for about 30 minutes, and then I will facilitate some questions after that point in time. So if you have a question, you can type it into the box there, and I will try and get to them as best I can and try and lump them a little bit together as best I can. So without further ado, I'm really happy to hand this back over to Todd for our third installation of this series.
Thank you, Alec. Hi, folks. For those of you who are returning, welcome back. And for any newcomers, welcome. Being in Canada, of course, it's important for us to welcome newcomers of any kind. So here we are. Part 3 that we're about to talk about is specifically about looking at integration and collaboration. So specifically what that's going to mean is we're going to talk about integration of programs like mental health programs with addiction programs, because that's been a sort of an ongoing process at various speeds across the country for probably the last decade or two. It's been really scattered and happening at different rates. So that's an issue, and the issue of collaboration, particularly in relation to interagency and interdepartmental kind of collaboration, because we've all sat on some types of interagency or interdepartmental committees looking to do things like, as we would say, stop people from falling through the cracks. And that's kind of why we tend to approach the merging of things, the integrating of mental health with addictions, and the collaboration between agencies, departments. It's this idea of stopping people from falling through the cracks. So we're going to talk about how do we do this in a way that makes that process client-centered and therefore more effective. And first, a reminder from the last two webinars that the concept of client-centered, in my definition and the way I keep trying to push this, means the client is the priority, which means doesn't mean the client's important. It means the client comes prior to or before all other considerations, whether they be money or financial or political or administrative or anything. So that's what I mean when I say client-centered. I mean that when we're making a decision and faced with competing interests, the interest of the client in terms of a system-related decision comes first, comes prior to. So that's just a foundation piece for anyone who hasn't been on the last two. So let's talk about the word integration. So we're talking about bringing mental health and addiction programs together. Well, here's one definition that I found from the multiple dictionaries online, and it's combining one thing with another so that they, and this is the key phrase, they become a whole. So it is about taking two things and ending up with one that actually functions like a whole. That's important. Now, as we look at the issue of mental health and addiction integration, the movement has been happening, and in most jurisdictions there is an integration in place. or some kind of merger. And the reason that it's moved this way has been partly for administrative reasons. There's no question about that. Partly senior folks and politicians have seen the administrative efficiency that can be created by getting rid of, 2 CEOs or 2 directors and putting all the managers under one, and that kind of thing. It creates a more efficient upper level in some ways, and so there are potential savings and those types of things that come from an administrative perspective. But the other reason, and the other stated reason that this tends to have happened and is happening, is better client care. So let's take a look at some of the ways that integration has happened. So in your area, some of these things may or may not apply, but these are some common steps that have been taken around integration, some common approaches. So one is you take the 2 programs, you put them under the same senior administration. So that might be the same CEO, the same director, the same vice president, the same something. And so and the rest of the structure is a different issue, but you merge or integrate at the top level administratively. Then you get to go through the renaming, rebranding. You create maybe a new logo, a new name, so it's no longer separate names. And you create some kind of single intake process so that people actually see it as one organization. They find one phone number, they find one website. You create that unity from a visibility perspective. That's part of the rebranding. It's very, very common. It's one of the essential things from an administrative perspective. But if that's the extent of the integration, if that's what people think integration means, then we end up still with staff in those programs who think of themselves as being part of an addiction program. We still have staff who think of themselves as being part of a mental health program. They report to separate managers. There's a mental health manager, an addiction manager, and those managers might happen to report to the same director or same something. But that fact really matters a lot, and it matters a lot because what ends up happening is the client still ends up facing 2 separate streams of service because you have a group of addiction staff who are essentially still an addiction program. You have a mental health program. They're just not branded anymore or standing on their own with a distinct identity or corporate identity or public identity. But the client still might come in through the same intake system, but then ends up, depending on what seems to be presented, will be channeled into either an addiction program or a mental health program, like to an addiction therapist or a mental health therapist, or perhaps in some areas to some unique middle ground program that might be called a concurrent disorder program, where anybody that seems to have some of both of those issues might get put in that one. But we're still streaming them and maintaining separateness so that the client experiences separateness of programs, separateness of their own issues perhaps in lots of ways, so that because they're dealing primarily with one issue with one person in what they think is a program, and a different issue in a different program with a different person. So we're segregating a person into pieces. And so that's not really what's best for the client. It might be administrative integration, but it's not client-centered integration. So what does client-centered integration look like? Well, first of all, you create clinical level integration. That's where it matters. Quite frankly, having spent many years as a director and other positions in the public health system, I can tell you that my belief really is that the people in positions like mine are the least important in the system when it comes to the concept of client-centeredness, because it is at the clinical level where the client actually talks to people and receives care. It's at that level that it needs to be integrated. Whether the administrative level at the top is integrated or not is really somewhat irrelevant. And, I know people will hear things like function follows form, that kind of thing. So, yeah, you have to have the structure in place, and there's some truth to that. However, when comparing which is more important, the administrative level merger or the clinical level integration, so that a person comes in and gets treated as a whole, then the clinical level is where you need to work. So creating a single program identity among staff is a critical piece of achieving that clinical integration. So this comes from social psych research. The social psychology has been a field that has been underutilized when it comes to this whole area of integration and collaboration. And in fact, it is the field that has all the history of research on intergroup relations, which is what this is about. So if you have staff who still think of themselves as being part of one piece of a program and not the other, and so they think in terms of us and them when they're doing their work. There's us who do addictions work, and then there's them who do mental health work. Then you'll still have you won't have what the next bullet says, which is this perception of one-stop shopping experience for the client. The more staff think of themselves as one, they talk as we, not as us and them, or our program, that program, this service and that service, but just us, our program, period. The more we do that, the more we create an experience for the client that actually feels like one-stop shopping. We have to eliminate duplication. Our clients, when we are integrating, we still will end up very often, if it's just the administrative structural integration that we do, we end up at the client level where there is duplication of all kinds of things. We may find that, in fact, the client is being asked some of the same questions multiple times as they are moved from one person to another, from one stream of a program to another. Somebody will start from scratch and gather some of the basic information that was already gathered somewhere else. When, in fact, if structurally it's one program, then this client should only have to answer a question once. Unless, in a clinical setting, you're re-asking questions about their mental state as part of your therapeutic intervention. That's different. I'm talking about the system. If the system is making them do paperwork or answer questions or go through hoops that they've already gone through once they entered this single program, then we are duplicating and causing inconvenience for the client because of our need to ask questions twice, because of our structure, not because it's best for the client. So eliminating duplication. The concept of referrals is a fascinating one for me. I've always found it interesting because the word referral has historically been used to connote the idea of sending somebody from one service or one program or one organization to another one. So a physician referring somebody to a diabetic clinic, that is a referral from one entity, a physician's private practice, to another entity, a health authority's diabetic clinic. And historically, addiction and mental health, each of those streams have been separate entities in most jurisdictions. They've functioned as separate organizations, or programs, if not organizations. And the result of that is that there's a history of doing referrals. So someone comes and is sitting with an addiction therapist, and it's discovered that this person is having some other issues that are more in the mental health stream. Then they would be referred, or vice versa. So somebody is coming for help with their depression, and it's discovered that this person is using a lot of cannabis to self-medicate, or using alcohol, or using something else to self-medicate their anxiety or something. Well, then they'd be referred to the addiction program to deal with that part first, or at least separately. Well, if we're one program, what's a referral for? Your coworkers. Share the case. Just walk down the hall or pick up the phone and call the other office or whatever it is and talk to your coworker and say, I've got a client here who I think could use some other kinds of help that I can't provide or that we could provide together or whatever, and so let's set up an appointment. There's no need to have the formal process in the system. And so this might seem trivial at first glance, but if you consider the fact that to do a referral, is going to take up anywhere from, I'm going to say, anywhere from probably 5 to 30 minutes of a clinician's time, depending on how much detail has to be put in the referral form that happens to be in the structure. Well, that's clinical time wasted. There's no need for that. That's actually keeping wait times higher because it's another chunk of paperwork. And as social workers, you all know that the job of being a social worker is one that involves doing way more administrative and paperwork than you should be doing, and in most program areas. And so many people doing clinical work find themselves doing more administrative work than they should be. And that's clearly less important than seeing clients. So every bit of this administrative stuff that can be eliminated should be. And a referral that's actually within a single program, it doesn't make sense. You're not sending the person anywhere. You're just collaborating with a coworker for the best service for this client. And so the bottom line of what a client-centered approach to integration of these two program areas would look like, the bottom line is that it has to come from the client's perspective. The client has to experience the system as, like the definition said, as a whole. If the client still experiences it as separate pieces, as separate streams that each fix one part of me, anything like that, then it's not client-centered, and it's not actually integrated. We don't have an integrated program if the client doesn't feel like a whole person and doesn't feel like the system is a whole system that treats me like a whole person. So let's move outside of the program itself, and let's look at that interagency and interdepartmental kind of collaboration. So this, I say interdepartmental to allow for things like mental health and addiction programs collaborating with the emergency department of the health authority or the health organization, or perhaps the primary health care branch, or the various other components, the public health program, the other components that actually have legitimate reasons to be working together. And so this definition, it allows for that interdepartmental stuff, but a lot of it I'm going to be talking about interagency work. So collaboration, again, we've got this idea of two or more people, in this case I'm talking organizations, working together to create or achieve the same thing. That is the most important part of the definition to remember. It's about them achieving the same thing. And in some definitions I found they contrasted the word collaboration with cooperation. So if you've got two organizations coming together to work on their own things and sort of help each other with their own things, achieving their own things, that's cooperation. But coming together to achieve the same thing is collaboration. That sense of oneness is one that we're going to come back to. So a common approach. So, after I go through this, I'm going to ask you to put up your hands if you've experienced this, and I won't be able to see you, but I'll sense it. So, common approach. Committees of agencies come together. Someone decides there's too many people falling through the gaps and falling through cracks, and so a lot of time is spent developing terms of reference. Your first, 2 to 10 meetings, it's on the agenda, and you're wordsmithing it to death. And I can almost feel the frustration from some of you right now as you roll your eyes having had that experience. And so that is an OMG moment, right? Like, God, make this stop. Well, there's just too much of that time spent on trying to get that part perfect when we overcomplicate it. As if it's a legal document that is going to have huge impacts. And really, most of these interagency kinds of committees, when the terms of reference are finished, they're put aside and they're only revisited, very, very rarely. Just kind of, because it might be time to revisit to see if we're still following them. Or perhaps we've run out of productive things to do and it seems like this would be something productive to do. So most of the meeting time, though, is spent actually over months or years, is spent sharing information. So on the agenda, you'll see commonly a standing item that is something like roundtable sharing. So we'll go around and, we'll say, okay, well, Child Protective Services, what's new with you? What programs are you guys doing? What's new? Has anything changed that we need to know about? Mental health and addictions, what's new with you? Policing, tell me what's happening there, any new stuff. And so they report on trends or changes in their program. They'll report on a grant application or something that's happening. They'll report on anything. Nonprofits will be reporting on staffing changes because they only have 2 or 3 people perhaps, so it's a big deal. So a lot of time spent information sharing. Okay, that's great. Each agency sitting at the table, you will find often, is really hoping that the others around the table will make substantial changes to their own policies and practices so that then we can work better together. So so having been part of mental health and addictions, I can tell you that because mental health has been under, and addictions both separately and then combined, have been under scrutiny by the public for quite a long time related to things like access and wait times. Because of that, when mental health and addictions goes to the table with the other agencies, there are some people there who are just thinking, if you guys would only get your act together and give us better access so that we can get our clients in when we have a child who's in a home where there's a risk and there's a substance use problem there, we need to get our client into your program. Why can't you just make that happen? So whether it's stated or not, people are looking to each other to make significant changes because they believe that's where the barriers are to good collaborative work. And this sounding familiar to some of you? Each agency is careful about protecting its boundaries. So, turf protection. They're careful about making sure that they don't commit to doing anything that is outside of their own mandate. You can't step over that line, not even a bit. You can't allow other people, other organizations, to do some of the work that might be considered the work of your organization, because, again, that would be a breach of the boundaries, and we need to protect the boundaries between the organizations. We each have separate jobs to do, and so that becomes a focus where, and you'll see some organizations do that far more than others, and they'll try very hard to make sure they just never commit to going very close to that line, that circle that they've drawn around their own program that kind of says, we do what's in this circle, and we don't do anything outside of that circle. That's all your job, everybody else. And so they'll keep their toes, a few inches back from that line, not even push up against it. They kind of stay back from it pretty conservatively, and for all kinds of reasons. But that is a common kind of a thing, a common dynamic we experience when we all come together. So what's happening in the room is we have a bunch of separate agency identities. So everybody in the room is there wearing their own agency hat, wearing their own program hat or organizational hat, and focusing on the entire discussion from that perspective. And so that's why they're looking to others to fix things. That's why they're looking to maintain their own sense of identity as an organization. That's why they're also trying to achieve their own goals. So, like the example I just used, if I'm there from a child protection agency, I might be looking to have mental health do a better job of giving me access for the clients that I know need that care in order to protect the well-being of this child in the future. And so, I'm trying to achieve that goal as my primary goal. I see this as an opportunity to potentially build a relationship and influence that other organization so that they can help me achieve that goal of the organization I'm paid to work for. So what would a client-centered approach to collaboration between agencies look like? Well, it looks like little or no time spent on terms of reference, because really the bottom line is we know that most of those documents are never paid attention to. They don't mean anything to most people around the table. They don't actually have great influence on what's going to happen. And the bottom line really is that the most important thing that they need to state is that we're going to work as if we are a collective, and we are going to always collectively do what's best for the client, not what's best for my organization's agenda or yours, not what's best for the comfort of the people in the room and not wanting to debate an issue. We're going to do what's best for the client. So put down a few key principles. That's it, and move on, because otherwise, again, we're wasting time that you could be spending creating client-centered systems back in your own organizations. And we know that these meetings become wastes of time. That's why the attendance fades over time, right? That's very common. Attendance fades because we spend too much time on stuff that's not really important enough, not really relevant to the members of the group. So none of the time should be spent just sharing information. None of it. There's no need for that unless it's actually specifically necessary as part of a decision-making process. So we're going to be, instead of talking about what people have done, what everybody is doing separately, the focus should be on what we are going to do. What are we going to change? What structures, what relationships, what processes between our organizations are we going to actually change? Talking about the way things are right now, what everybody's doing separately, really serves no purpose. That could be done with an email. It's really that simple. That could be done with an email. Or maybe in your first meeting you do a brief introduction to things and give people a handout. There. That's done. We've got the basics. But that's not the point, because the point to collaboration is actually to create the opportunity to achieve a common goal for the future. The past is the past. So what you have been doing separately is really only relevant to the extent that it's needed to make a decision or to make a change in how we work together. So bring it in only then. So you're focusing always on what are we going to do now, not can everybody tell us what is happening. And so the other thing that's needed for a client-centered approach is that each agency actually needs to be focused on changing its own policies and practices. So remember I said that, it's common for us to be looking across the table and kind of thinking, geez, I wish they would change that rule because that rule is the one that's really getting in the way. Well, instead of doing that, because you actually don't control that other organization in any way, you have no influence over that organization. It's not your job. It's not the reason you were invited to the committee. It's not what you're paid for. Your job is actually to improve the program that you run or that you represent. So go in with the humility and the recognition that my job is to come here and figure out what can I change about what we do, our organization. What can I change about that will actually improve collaboration? If everybody comes to the table looking across the table to others to make changes, we know what happens there, right? It's called nothing. That's what happens. So if everybody comes to the table thinking, I'm here to change our program to make it collaborate better, then everything changes, because everyone around the table is actually having that same focus, and change happens. In a client-centered approach, everybody is pushing the boundaries or the scope of their mandate. We have to bring our organizations closer together in what we do, not further apart. The further apart we draw those lines between us, the more cracks there are for people to fall through, because we're so hell-bent on not stepping over that line, on not doing anything that's not our job. We're so hell-bent on that we end up creating those cracks. We have to push that. We have to push it and say, okay, we're willing to add this to what we do, because, not because it's our official mandate, but because it makes sense for the client. The group needs to develop a single identity as a collective. In other words, I'm not here just representing mental health, trying to do what mental health is doing. I'm not here representing, CMHA or whoever. I'm here actually, I'm part of a we. In the room, we are an entity. We are a collective, and we are going to try to serve the best interests of the clients. So you get rid of the us, them around the table. And then you end up with, like the definition, you end up with this group that's trying to achieve the same thing, and instead of a bunch of separate stuff. And so then you've got a system, you've got a collaborative system that is actually client-centered, which is very different than what we commonly see. And so in the common approach, what do we see? The client experiences each of the agencies still as being different agencies. They're still each doing their own thing, and the client might be bounced around between them and getting a piece of me helped here and a piece of me helped there. And some of that is necessary and unavoidable because we do have different jobs to do, but they still experience them all as disconnected They feel like there's not enough communication, and a lot of that, of course, we know is related to privacy legislation, which is a topic for another day. But the client doesn't really see change coming. The client doesn't experience change between agencies as a result of the collaborative kind of committee or as a result of the merger at the administrative level of two programs coming together. And the client is still kind of like pieces and not a whole person. We still end up with that same experience. If you were the client, if your wife, your husband, your daughter was the client, you'd feel like a pinball in a pinball machine. You're still sort of bouncing around as not being treated as a whole by the system. Each agency might be doing great work, but together they're not functioning like a system. That's the part that is frustrating most of our public. It's not that they're coming across people who don't care. It's that those people who don't care seem disconnected. So I've got to move on a little more quickly here, but the rest of these are a little better. So how can you create effective integration and collaboration that's client-centered? Well, focus on the clinical level, on the client service level. Focus on the experience of the client. Come at it from that perspective. Always ask yourself, if the client was my daughter, if the client was my brother, how would I want these agencies to work together? How would I want these two programs to work together? It's really simple. Focus all your efforts at that level and far less on anything related to administrative stuff. Focus on collaboration that changes all the organizations, that pushes them into a more single client experience somehow. So again, it's coming at it from that perspective. Push the boundaries, push the rules, challenge organizations to go beyond what they're supposed to be doing and find places of overlap. Intentionally find overlap, because then there's no cracks to fall through. And create a single identity as a program, as a collective, as a group of agencies, a single identity coming at it from the perspective of what we know about intergroup relations. There are things we know that work to create that. So, make the experience of the clients feel integrated and singular. Don't make the experience of the staff or the administrators feel that way. Don't worry about it looking that way. Only worry about it feeling that way for the client. Eliminate the turf protection and the gaps. Keep those things as the focus of every decision. A little story about this, and I'm going to wrap up soon, Alex. So don't cut me off. But so this is a painting that was done by a client at the Canadian Mental Health Association Halifax Dartmouth branch. That was given to me after I spoke there, and they let me choose from hundreds of beautiful paintings. This one instantly jumped out at me because the minute I saw it, all I could see was interagency collaboration from a client-centered perspective. And I'll tell you why. Because each of these circles, think of them all as separate programs, separate organizations or service entities. Think of them all as separate. Okay? So where does client-centeredness live? It lives everywhere that you see an X. That's where collaboration lives. It is intentionally and only in the places where there's overlap. So if these circles don't overlap and there's space between them, then you might have a cooperative committee where people try to help each other as agencies. But if you want to collaborate, you put the client in the center of what the two agencies or three agencies are doing. That is the place where collaboration lives if you're coming at it from a client-centered perspective. You intentionally put the client in those gray zones. I wish I could have colored those zones gray. But you intentionally put the client there because that's where the shared work happens. That's where you achieve a common goal. That's where the client is treated as one, not as two. Because you don't see two X's for the same person, one in one circle, one in the other. You come together and make one place for the client, a whole person, a single goal. And we're going to stop there. And it'll be time for questions. Alec is going to facilitate that, and then I'll make another comment at the end before we wrap up.
Thanks so much, Todd. Thanks so much, Todd. Once again, just just really great stuff. We've got some questions coming in, but I thought I would start us off, particularly with what's happening in the context of Nova Scotia, where, of course, a few years ago we saw the amalgamation of a bunch of different health authorities into one massive health authority, and, of course, the languages around efficiencies and standardizing all of these programs. In terms of the impact of that on client-centered approaches, I'm wondering if you have any comments or concerns about what we've seen in Nova Scotia in particular.
Well, what I see and hear from people is that one of the greatest challenges of trying to formally integrate, one of the greatest ones, is actually creating that single organizational identity. But one of the risks when you go so big, and when you then focus on standardization across all of those organizations, is that you create rigidity where everyone has to do everything the same way. And that is the opposite of client-centered. Client-centered, by definition, is responsive to difference. Client-centered, so, the idea of integrating organizations, we have to be able to bring them together to see the client as one, but then be able to respond. And so there's a challenge there, and in Nova Scotia we have that same challenge because it's become so big that everything takes a long, long time to actually get done. Decisions have to go through so many channels to make any actual changes that are client-centered that the bottom line is that most decisions end up being centered around what the organization prefers. And so that's a common thing in mergers and integration and collaboration, is that the focus is around administrative concerns, around efficiencies and standardization and control and those issues. So it's not that they're bad people, it's that that's standard practice in administration.
Absolutely. I'll go to some of the questions here. First of all, there's a couple comments, and there were some folks who digitally said that they were raising their hands when you asked that question. So you had a lot of folks having that experience, particularly around doing that type of work and trying to work interagently. I do have a question here about the idea of a one-stop shop, and again, the idea of sharing clients' files, and that again, the notion that having to do a referral allows you to pick out only the pieces that need to be moved forward without sharing the client's whole file. And there's a question on what are your thoughts on that process, and is that important in terms of when we're looking at this collaborative work to be able to filter what information is being shared?
Yeah, I think. Well, first of all, I guess my first answer to that is that is, to some extent, in some jurisdictions, depends on the legislation, but that's always the client's decision anyway. The client always has, or frequently has, the final say on what gets shared where and when, other than in emergency and life-threatening kinds of situations, the exceptions. But yeah, I think that people need to know if you are moving a person from one organization to another, from one program or provider within a program to another, the information that's shared should be what's needed to provide the best care for that client, because that's respectful of the client's privacy, but is also ensuring the best collective work for the client. And if we have separateness, if we're not passing information along, because, historically, addiction and mental health, for instance, they've been like on separate islands and have refused to share information with each other in many jurisdictions because they come from privacy and anonymity land, and so that's been a challenge. But information still has to flow if we're looking to create that integration or collaboration that's truly client-centered. Information has to flow, or else we end up costing the client more time, more hassle, more frustration being asked the same questions that have already been answered. And if those questions, if they're logistical questions, demographic questions, that's an annoyance. But if they're sensitive clinical questions that have already been dealt with, already been talked about at length, then we're potentially causing harm because we're recreating what may have been a traumatic conversation instead of just passing that along and saving the client the feeling of repeating that. So it's an as-required thing we have to be taking, and reduce the inefficiencies and the discomfort of the clients, but provide enough information to do good work together.
Well, and at the end of the day, too, you're using your professional judgment, and you're relying on, our own codes and standards to guide what do I need to share here to get that collaborative practice. And so that process is embedded within our own experiences and working in collaboration with that client. I have another question here, particularly around that interdisciplinary work. And again, everyone who's on the phone today has that shared professional lens of being a social worker. However, outside of the discipline, particularly when you're dealing with perhaps other professions, may have a very different perspective on what client-centered looks like. And again, how do you start to negotiate, or how do you know what is truly client-centered and what the best decision is when you're dealing with these different professions in an interdisciplinary collaborative setting that may have very different perspectives on what that really truly means?
Yeah, I love that question. I love this topic because I know that sounded really weird and pathetic probably. You can laugh at me if you want, just don't put that online. The issue around that is that we need to, first of all, we need to be able to talk about client-centeredness in a simplistic way, not in a way that is full of all the jargon of every profession. Because when we come together as multiple professions, we each have our own unique language. It's like a pair of twins at the age of 1 who seem to be able to talk to each other and no one else knows what they're saying. Well, it's kind of like that. Within psychology, there's a language. Within psychiatry, within medicine, within nursing, within education, we all have our own jargon. And so part of the problem is that where we need to get into simplistic terminology. Client-centeredness means that when we're faced with a choice, we're going to do what is the best thing for the client. Now, that might lead us into a debate about what is the best thing for the client. And so we need to start to humble ourselves to recognize that we often are not the ones who know what's best for the client, and that we need to start to recognize the fact that the client knows and start to ask more and start to put ourselves in a position where we understand, where we might say things like, well, my classic question that I put throughout my entire book, more times than you'll ever want to read, is if the client was your mother or your son or your cousin, if it was that, then how would you want this part to work? What would you think is the best for the client in that case? Everybody can understand that approach. Doesn't matter what your discipline is. Take that discipline off, throw your jargon out, and answer the question as a person, and there will be far less disagreement. But having said that, I'm going to add to that and say the one thing that is missing the most in our collaborative efforts, I believe, as a social psychologist originally by background, the one thing that's missing the most is debate and disagreement as a necessary activity, not as something we have to tolerate, as something we have to demand from each other. Because we can't find what's best for the client unless we all put our own pieces of expertise, our own personal experiences, our own perspective about what I'd like for my mother. Unless we put that on the table and debate these issues about what's best for us to do collectively, then we don't have all the information. We don't have all the expertise. I can't stand here and say, well, social workers really are the ones who have it all wrapped up and have all the answers. That would be stupid. I can't say psychologists do. I can't say psychiatrists who are, they are the highest trained specialty in this field. But I can't say that they've got all the answers because they don't. None of them, no profession has it. Because if they did, we would have a system full of only that profession and we would have no wait lists and all healthy people. That's not the case. And it's not the case because we all only have part of the knowledge. And so when we're around the table, get it all out. And don't hesitate to disagree with people, because without disagreement, we end up with groupthink, which is the single greatest dysfunction in a collective that you can have. And that's going along in order to not going along to get along, not wanting to rock the boat.
Right. We've, particularly in Canada, we've seen this trend over the last 30 years, particularly within the administration of social services, towards that managerialism, and that someone with a business background can create a whole lack of efficiencies in here without having that knowledge. And I think a lot of folks experience, certainly mine being a frontline worker, is that standard and that business model gets put at the forefront and everyone is expected to conform. However, as we've noted, mental health and addictions are in our everyday debates and conversations, particularly at a political level, with a lot more of attention being paid to them. However, the disconnect between what particularly political decision makers want to see and what we're actually achieving oftentimes seems very disconnected. So there's a question on these lines, again, is how do we do this type of political advocacy, and how do we start to break down, or how do we start to make some connections between the outcomes that the political leaders want to deliver and these, administrative barriers that we continue to find ourselves in?
Yeah, that's funny how that kind of question has come up in all three of the sessions, and it comes up at many of the public talks that I do as well, because most of the people, probably most of the people online here, and most of the people doing a lot of this work, they are employed by an organization that is either directly government or that is funded by government, and therefore is kind of at an arm's length accountable to the elected people and, the CEOs. And so what happens is that there is this constant perception of everybody being gagged, that nobody's, you can't openly advocate against your employer. And that's basic labor law. You can't undermine the credibility of your employer. And so that creates a problem. It's been a problem for me my whole career. But that doesn't mean we can't introduce new ideas and new ways of doing things with good reason. And and if you've got a manager or a director or a VP or whoever you report to that simply isn't open to new ideas, and we know they exist at senior levels in lots of organizations, they're just not open to other people's ideas. This is the way we do things. And so if you've got that, then you've got a challenge on your hands. But you can still be part of advocacy outside of work as a citizen. You just might want to be careful about maybe not being the spokesperson. But that doesn't mean you can't be part of a group that's doing advocacy. There are groups online. I mean, in PEI, there's a group there that's it's called How Many Wade. Wade is the premier, and that group is advocating, as a collective. There are probably lots of public employees who are part of that, adding to the numbers. In Nova Scotia, there's a new one called How Many NSHA and IWK. The same thing. And so people can be citizens. You're allowed. But we need to start to introduce the new ideas, because, and I'm going to wrap this question up in 1 second, but one of the problems is that many of the people doing the advocacy for change in many of our public sector programs, but including mental health and addictions for sure, they advocate for more because they don't know much about what they should be advocating for. The people in the systems, so many of you know where the flaws are. We know that it's the kind of stuff that I'm talking about here. It's the kind of stuff I've written in the book. I've tried to kind of take the roof off the building and let the public look in and say, oh, my God, that's why we have these wait times. I didn't know that. And so we need to start to introduce these kinds of different thinking, because more of the same doesn't give us different. It's time to start to talk about different and introduce these new ideas. I mean, not new ideas. I don't mean they're my ideas and they're brand new. No one's ever thought of them. But they're new to the system. And we need to start to just help people think differently. And that, using your clinical skills, your influence skills, start to use that to try to get people seeing things a different way, and change will gradually start to happen. Great.
Again, it is about recognizing your own power, doing that critical self-reflective work, and finding those avenues within your systems. I have another, probably a final question here, and then you can have some time to wrap it up here, Todd. But there's a question here from Sylvia, who writes, as a frontline addictions therapist, I'm privileged to go to another agency one day a month to collaborate services for clients and minimize hoops for our shared clients to jump through. Do you have any advice for how I can maximize on this opportunity. I spend the day at a women's center and housing program, and I come with all resources to streamline the clients right into our program currently. So again, it's an opportunity, and how do you maximize that time to collaborate, to be collaborative?
Wow. Well, first of all, congratulations. That's fantastic. And there are lots of those stories, I think, across the country, in little pockets where there's that openness is there. But what I would suggest is just start to have conversations, if you're not already, but my guess is, from the sounds of it, you probably already are. But have conversations about the concept of together. What can we do together? What are the common goals? So I love the fact that you're there for the sake of making it easier for people to come into your mental health and addiction program, because that is what I've said earlier, which is come to the table offering to change your own program, not looking to change other people's. Right? That humility, that self-focus for change, self-reflective approach, it gains you huge credibility with other organizations. So you're already in that position. I would say just start to talk, open conversation more and more about, are there other ways that we can make this easier for people? Are there other kinds of things that maybe you haven't thought about, but the staff you work with at that organization might think about? And just try to plan for a half hour once in a while just to have a conversation that is more like brainstorming. It's more like, and my suggestion would be start off with the question, if your husband was the client, if your daughter was the client, what could be done better? And so start with that and just go with whatever comes up and push boundaries as much as you can, because you've got a great opportunity. And I love the one-to-one agency collaboration, because there are good reasons why that's more effective than multiple agencies.
Absolutely. So we'll start to wrap up here. What I wanted to say to everyone listening is that we are hugely thankful here in Nova Scotia for our partners at the Canadian Association of Social Workers, who are looking to host a whole whack of webinars over the next year. So for us in Nova Scotia, if you had ideas on what you wanted to learn more about, of content you wanted to see coming out of the Nova Scotia College of Social Workers, feel free to send me an email at any time. I'd love to hear from you, and we'd love to be able to develop that opportunity for folks. Todd, I'm going to pass it over to you for some final words, this being your last opportunity to address this crowd. And again, thank you so much for your time.
Well, you're welcome. It's my pleasure. I've enjoyed every bit of this. So, folks, the last couple thoughts, I guess a couple things. One, keep promoting new ways of thinking, and keep promoting the idea that the design and operation of the system, most of our public settings, that needs to be the focus, because you're all, of every profession, people are doing really good work once they're face-to-face with clients. But the systems we work in tend to be the frustration, both for the clinical staff and for the clients. So focus at system levels, and that's what my book is completely about. It is not a clinical book in any way. It's about how to change the systems. If any of you are interested in talking to me more, if you have questions you didn't get answered, my email address has been on the screen there for a while. My phone number's there. My website, all of that stuff is there. Please contact me. Feel free to connect with me on social media, follow stuff if you want to keep up on some of the advocacy things. And if I can help in your area of the country, that's the business I'm in, and I would love to come and visit. And on this particular topic, the last thing I want to say, this particular webinar about the interagency collaboration kind of work, I actually have a full-day workshop that I developed that I pilot tested in St. John's, Newfoundland recently that's available. So if you want to get your local agencies together and have a collective training kind of process, and really boost the effectiveness right through the roof, then that is a specific kind of thing that I would love to be able to come and do and change the way you work together. Otherwise, thank you for tuning in, and when the link comes out for this to public, share it with people, because that's the stuff that will help push change.
Todd, once again, thanks so much. Again, it's been a great opportunity to hear about how we start and the ways we need to start thinking about systems changes, and giving us some real actions that we can take into our places of work to really bring these system changes that are desperately needed to life. So thanks again, and thanks everyone for tuning in.